All right, so welcome everybody to March 14th, 2023 Medical Grand Rounds. It's a great pleasure to be hosting Dr. Duque. Before I move on, I'd like to acknowledge that McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which the world now gathers. I'm going to remind everybody that to mute themselves and that we ask people to put in their questions in the chat for the discussion period. And now it's my great pleasure to introduce Dr. Gustavo Duque, known to many of you, but also back rejoining McGill, one of our 2022 star recruits in the Department of Medicine. And we're certainly grateful that Dr. Duque has joined us or rejoined us. Dr. Duque is a geriatrician and biomedical scientist in the areas of age-related bone loss, osteoporosis, sarcopenia, osteosarcopenia, and frailty in older persons. And he's been prolific in this area, publishing over 280 publications and 5 books. He completed his medical training in Colombia, did his geriatric medicine at McGill University and his Ph.D. at McGill University, and came on staff in the Department of Medicine in the Division of Geriatric Medicine and did his research at the Lady Davis up until 2007. Then moved to Sydney, Australia, where he was the head of geriatric medicine until 2015. In 2015, became the chair of medicine and the director of the Australian Institute for Musculoskeletal Science at the University of Melbourne, and then joined us last year, as I mentioned, as a full professor and the Dr. Joseph Kaufman Chair in Geriatric Medicine, and also the director of the Ruiz Medical Center of Excellence for Sustainable Health of Seniors. In his spare time is the editor-in-chief of the Journal of Gerontology and Biomedical or Biological Sciences. So thrilled to hand over the floor to Dr. Duque, who's going to speak to us about osteosarcopenia, where muscle, bone, and fat collide.
Thank you very much, Dr. Roger, for the nice introduction. And thank you for the invitation to talk to the members of the Department of Medicine. It's a real pleasure to be here, to come back to McGill, to my alma mater and my house, my home, and also to be able to share with you today the new evidence. And probably this is the work of my last 15 years working on the different aspects of this topic. And I will try to summarize those 15 years of experience into these 45 minutes or so, and introduce some of some terminologies that maybe some of our attendees have not been familiar with or have not been told about in the past. But I think that it's important that I will start by my conflicts of interest. It's important that we define why are we talking here about muscle and bone. And the reason why we're talking about muscle and bone here is because these two tissues develop from the embryonic development. They develop and grow together. They are connected, they are linked, and they are biologically originated from the same precursor, which is the mesenchymal stem cell. So these tissues, as I say, when they grow together, they end up becoming a significant part of our body composition. In fact, bone and muscle constitute 55% of the body composition in a healthy older adult. So we are talking about 55% of our body today. But something happens to these tissues. Once we reach that growth, then due to aging, we start progressively losing the tissue in both muscle and bone. This is a study that we performed in Australia. It's actually the largest study on body composition in the world. This study was conducted by my postdoctoral fellow, Ben Kirk, which hopefully we will have at McGill next year. Ben quantified body composition and consolidated the data of 15,000 adults aged 18 to 88. And as you can see here, there is a progressive decline in muscle mass from the 20s to the 80s, both in men and women. This is what we call, and this is important to clarify, this is what we call normal muscle, age-related muscle loss. So it's originated and induced by the normal healthy aging process that happens to everyone. There is a variability, of course, but it's the normal variability within the reference range. A similar study was done in a smaller sample by another Australian group, our collaborator Julie Pascoe at Geelong Osteoporosis Study, one of the largest also in the world. But in this case, they quantified bone changes in bone mineral density with aging. And you can see here the femoral neck and total hip, which are very illustrative of what happens with bone with aging. You can see here a progressive decline in bone mineral density in both, in this case in women, but in both sides, in femoral neck and total hip. What is also very interesting from this perspective is that at the same time that we have this decline in bone and muscle mass, we observe also an increase in the fat that infiltrates the muscle and bone. This is data from the UK Biobank, and using MRI scans to quantify fat infiltration in the muscle and bone, where aging was clearly associated with an increase on on fat infiltration. And here, I would like to introduce the third player in this story. We're talking about bone, we're talking about muscle, but interestingly, with aging, fat becomes another player in the story. And if we look, when we juxtapose the curves of age-related bone and muscle loss, we can see that the curves are relatively similar. We can see here that there is this progressive decline in both men and women. In women, bone declines very rapidly during the menopause years. But in general, we can see that these tissues which grew together and developed together, now they are declining together. And this is what we call the normal, again, age-related bone and muscle loss. But there is a subgroup of our older population that, due to the presence of risk factors that are listed here in the top of my slide, all these risk factors are determinants that some people, some of our older population, could have a more accelerated loss on muscle and bone. What is interesting is that when these risk factors are present, both tissues decline very quickly and very concomitantly. So we have here physical inactivity, aging itself, and I'm going to introduce a few concepts such as inflammaging. I already mentioned about fat infiltration. All these are considered as risk factors to the progressive decline. Before, we used to talk about separately and in some kind fragmented way of bone loss and muscle loss as if they were happening separate and having sarcopenia and osteopenia, osteoporosis as independent entities. Now we realize that, or we're starting to realize that risk factors for osteoporosis and sarcopenia are almost, if not identical. So here we have two conditions, osteoporosis and sarcopenia, that have the same or share the same risk factors, are consequence of these alterations in the communication between muscle and bone, and the other is a bidirectional crosstalk. We have the fat, which is starting to infiltrate, and all together, these changes will induce or will increase the risk of falls and fractures. And this is what we don't want to happen. We want to first identify the risk factors, second, identify the conditions, third, understand the pathophysiology that is shared by both conditions, and fourth, prevent the adverse outcomes that are associated with osteosarcopenia. Again, this took us like probably 15 years to come out to this conclusion that we are talking here about a condition that has two, or in geriatrics, we call it a geriatric syndrome, that has two components, two diseases. One is osteopenia, osteoporosis. How we identify osteopenia, osteoporosis, this is very clear in practice. We diagnose it by bone mineral density and or a history of previous minimal trauma fracture, or we identify sarcopenia, and that has been a little bit more challenging because we have three definitions for sarcopenia: European, American, and Asian. And some of them have been updated at this moment. Our group belongs to the GLIS initiative, the Global Initiative on Sarcopenia, coming together into a global definition. So hopefully this will be sorted soon. But at this moment, we have three definitions. What is important here is that first, we are not generating a new disease. This is a combination of two diseases. Second, it's very easy to diagnose because if somebody has osteopenia, osteoporosis, independently of the definition we use to identify sarcopenia, the person has osteosarcopenia, and that determines a higher risk of adverse outcomes. So as Dr. Roger already mentioned, I'm also a biologist, a basic science, a biomedical investigator, and I've used the new concept that is coming very on top of the priorities around the world, including the National Institute of Aging, the CIHR, that we denominate now as geroscience. Geroscience is interesting because in geroscience, what we try to do is to identify the mechanism, biological mechanisms shared by different chronic conditions. And we think that osteosarcopenia is the typical example of a condition that should involve all these different mechanisms. You can see here around the concept of osteosarcopenia, what we call the hallmarks of aging. So what happens in aging cells that are exposed to the aging process and the bodies when are exposed to the aging process, there are alterations in metabolism, in stem cells and regeneration. You can see all the different components. And you will notice that in my slides, I will include some of these components just to highlight that we are exploring the pathophysiology from these different perspectives. So when we talk about osteosarcopenia, we are talking about two tissues again, bone and muscle, and probably three different ways of looking at the biological mechanisms. First, we are looking at the common mechanisms, things that are happening at the same time in muscle and bone. The second component could be that defective muscle leads to defective bone. So something is happening in the muscle cells that affect their function, but at the same time, they affect this crosstalk between muscle and bone. And the third one is that defective bone leads to defective muscle. When I did my Ph.D. here at McGill with Dr. Richard Kremer a while ago, we talked about the bone as a relatively passive tissue. Now we know the bone is a very active, metabolically active environment, a very metabolically active tissue that has a major impact on how muscle works because of their connection and their crosstalk. Very quickly, I'm going to go over the common mechanisms, and there are two that we are particularly interested in my group. This is the one that I have been working for a while, the fat infiltration of muscle and bone, trying to understand how does it generate, what are the consequences, and how can we identify and manage it. Coming back to the story of the growth and development of muscle and bone, we know that the bone-forming cells, osteoblasts, and the myocytes come from the mesenchymal stem cell as the precursor, and adipocytes also share that precursor. So we think that if there is alteration in upstream, when we have the mesenchymal stem cell differentiation, then it will affect the differentiation into osteoblasts and myocytes, favoring the differentiation to adipocytes. What is also very interesting is that this capacity of the osteoblast to produce osteokines, which are factors that are secreted by the specifically by the bone cells, and the capacity of the myokines in the context of osteosarcopenia is affected by these adipokines. And I just want to show you a muscle biopsy with sarcopenia and a bone biopsy with sarcopenia. There are major similarities. One of them, you can see here how the fat infiltrates the muscle, and it doesn't only infiltrate the muscle around the fiber here, but you can see fat inside the fiber. This is important because we are not talking here, and I would like to start by mentioning that we are not talking here about obesity. This is independent of the patient's BMI. This is a fat that has its own particularity that infiltrates the bone and the muscle progressively. When you compare this muscle, this sarcopenic muscle, with this osteoporotic bone in your right side of the slide, you can see that at the same time that we have these bad trabeculae, we also have the fat infiltration not only around the bone, but also inside some of the lacunae where the osteocytes, important cells that control the bone metabolism, are hosted. One of the major questions we have is how similar the fat that infiltrates the muscle, the aging muscle, is to the fat that infiltrates the aging bone. And I find this study, this is a study that we did recently in collaboration with Marco Brotto in Texas. This study was conducted by my postdoc, former postdoc, Dr. Ahmed Al-Saedi, who, by the way, is our speaker for today at the Musculoskeletal Rounds, and he's now in Boston as a postdoctoral fellow at Harvard University. And basically what we did here was a complete, comprehensive lipidomics analysis of the bone, muscle, and serum fat. And what was interesting here is that we were able to compare in aging mice and look at the composition. We found that the composition of marrow fat and bone marrow fat and muscle fat is very, very similar. What we also found is that the arachidonic acid and fatty acids are significantly increased in both. Again, very similar kind of findings. So I will not go into all the details, and some of you who joined us yesterday at the Jewish General Hospital Grand Rounds, I talked a lot yesterday about this communication, the fat impact, but this is a summary of what we have found. In the left side is a summary of what our groups and others have reported in terms of the effect of what we call the white fat in the bone marrow, which secretes triglycerides, fatty acids, and adipokines, all these together affecting bone formation, osteoblastogenesis, mineralization. For those of you interested in hematopoiesis, it really affects this red marrow and induces apoptosis, dysfunctional autophagy, and osteoclastogenesis. If we compare all these processes with the muscle, of course, muscle and bone are not the same. Bone is mineralized, muscle is not always mineralized. So, but we can see that there are probably the same characteristics, the same effects of this marrow, of this fat infiltration in muscle. Overall, what the fat infiltration induces is a catabolic stage where differentiation and function are affected, and dysfunctional autophagy being a mechanism to clean up the garbage that the cells produce, and cell survival are affected in both tissues. So the question sometimes that we are asked is, what is the mechanism? How can we explain this fat to start infiltrating? How these stem cells are affected? And I think we have as many theories as attendees in this room. We have so many different theories, and I will just share with you our own working hypothesis and a little bit of a story. This story started with this patient. We reported this case in a long time ago in 2002. It's a progeria syndrome. This girl was a Brazilian girl who had Hutchinson-Gilford progeria syndrome, and she showed severe bone changes and also muscle alterations. What was interesting from this story is that 1 year later, there was a group from Nicolas Levy in France that reported the mutations on these patients based on a protein of the nuclear envelope that is called lamin AC. So it's part of the cover of the inner nuclear membrane. And what is important here very quickly is that lamin AC is attached to this complex system of that regulates cell differentiation. Cell differentiation that is important, again, to be working well in the context of bone and muscle formation. So we did a few experiments, just a couple of them here. This actually was an experiment that we conducted at the Lady Davis Institute a while ago, where mice deficient in lamin A were osteoporotic, severely osteoporotic. And interestingly, when we took the bone marrow cells of these mice and cultured them, they were predominantly differentiated into adipocytes. And that allowed us also to do another experiment, this one in Sydney, where we characterized the musculoskeletal phenotype of the lamin A knockout mice. And you can see here the histology of the lamin A knockout mice, where we see in the muscle the same fat here in red that we observe in the sarcopenic muscle. And what is interesting is in the right side of the slide, I'm showing micro CT images where all these yellow areas in the muscle are fat. And these brown areas in the bone marrow is also fat. So here we have, and we propose, therefore, that lamin A knockout could be a good model, animal model for osteosarcopenia. So this is something that I use always as an argument to justify the concept of osteosarcopenia, is that if there is a disease, there is a condition that exists, there must be a mouse model for it. And that's why we proposed the lamin A knockout mice as the mouse model for osteosarcopenia. However, we have not been the only ones proposing this type of models, but in some sense, we understand that in our understanding of the lamin A role in the mesenchymal stem cell differentiation, again, this is a summary of what we have done for all these years, is that if the cells have low expression of lamin A, they become, basically they show the aging phenotype with predominantly differentiation into adipocytes. If they are in young, healthy stem cells, we have low expression or higher expression, of this lamin A. But again, we're not the only ones reporting models of osteosarcopenia. This is an interesting one, very much associated with geroscience, a mitochondrial dysfunction, DNA mitochondrial dysfunctional phenotype, mice that show osteosarcopenia. They were clearly proposed as osteosarcopenia. And there is evidence from McGill University. This study was performed by Brad Richards and David Goldsman here at McGill, where they also reported this mouse model as another type of model to study osteosarcopenia. It's interesting because this was a very interesting approach, starting with genetics in humans and then moving into basics, into the mouse model, and also identifying a molecule that still is poorly understood. We don't know if that's a more metabolic or is related to inflammation, but it's definitely very interesting to explore and very much related with geroscience. For those of you who are clinicians, this has a significance, a clinical significance. This is a study by Andy Wong in Toronto, where they look at the marrow fat and muscle fat in older persons, around 300 postmenopausal women in the AMBER study, where they reported a larger amount of muscle fat and higher bone marrow fat is associated with a higher risk of fracture. So there is a significance if we find somebody or we find a patient with fat infiltration in their muscle and bone, these patients are definitely at high risk of falls and fractures, and they are osteosarcopenic. The second aspect that we are exploring is the tryptophan metabolism. And in the tryptophan metabolism, it's interesting because this is a communication between the gut and the bone and muscle. Tryptophan is an amino acid, an essential amino acid, and most of this is metabolized via a pathway that is known as the kynurenine pathway. But it's interesting that with aging, the tryptophan is predominantly metabolized into a bad metabolite, which is kynurenine. If we have too much kynurenine, it has been associated with osteosarcopenia and higher risk of falls and fractures. What explains that, again, from the geroscience perspective, it increases a high amount of kynurenine, induces marrow adiposity, induces cell senescence, and dysfunctional autophagy. And all these mechanisms that I already mentioned as associated with osteosarcopenia. But we also have good news. We have a good aspects of this pathway, which is the end product here that you can see at the end of the slide. It's called picolinic acid. So we have been exploring this pathway for a while, in which we know already about how bad it is to have too much kynurenine, but at the same time, how good it is to have picolinic acid, because we have been able to report that picolinic acid facilitates the differentiation of bone marrow cells into osteoblasts and bone formation. So here we had two stories that are common mechanisms: laminate deterioration, changes in tryptophan metabolism, that we are focusing on at this moment to understand the biology of osteosarcopenia. Very quickly, when we talk about defective muscle that induces defective bone, we have the old paradigm that they used to teach us at the medical school, that muscle and bone are connected by mechanical forces. So it's still valid, but it's probably less than half of the story when we talk about connection between muscle and bone. Here we have a connection that goes beyond mechanical. At this moment, I always give the same examples. My quadriceps is communicating with my clavicle, even if they are not mechanically connected. And how is this communication happening? We have what we call good and bad myokines. Good myokines that have the capacity to induce myokines, talking about metabolites that are produced in the muscle that reach the bone and induce bone formation, decrease bone rest, or regulate bone turnover in a positive manner. So if we exercise, if we are active, and we have a good nutrition, we have a good muscle health, these growth factors, these positive growth factors increase and go to the bone, induce bone formation. The contrary happens when we are immobilized, or we are lying in bed for a while, or for any reason we don't move. Then we have an increased myostatin. And this myostatin has an inhibitory, very important inhibitory effect on the muscle, but at the same time, interestingly, it has already associated with bone resorption and bone loss. What about the other side of the story? So we have the defective bone that has an impact on muscle. And a typical example here, there are two good examples. One of the good one, osteocalcin, a very specific protein that is produced by the osteoblasts, and that has an important impact and effect on the metabolism in muscle. And some people say that also muscle formation and muscle biology. But at the same time, we have at the other side of the story, sclerostin, which is a very strong inhibitor of the osteoblast formation. So if we are lying in bed, sclerostin levels increase, and it inhibits bone formation. But also more recently has been some evidence that sclerostin also regulates muscle. Again, for the clinicians in the Zoom, in the webinar, we have some preliminary evidence, and we and others have preliminary evidence that some of these myokines and osteokines have a relevance in clinical practice. One of them, myostatin, I already mentioned about myostatin in terms of the biology, but there has been some preliminary studies looking at the relationship between high levels of myostatin and low bone mineral density. This is a protein, again, that comes from the bone, osteocalcin. We are particularly interested in this one. This is a study published by our groups in Melbourne by the Itamar Levinger, where undercarboxylated osteocalcin correlated with muscle strength. That was probably one of the first ones that really looked not only on metabolism, but also on muscle function. Sclerostin, preliminary evidence, small Korean study, where there was a correlation between high levels of sclerostin and low muscle function, again, connecting osteokines and muscle function and differentiation. This one is one of my favorite ones. This is rank ligand. Rank ligand, it has been known forever in the bone biology field, where we know that rank ligand is a very strong stimulator of bone resorption and osteoclastic activity. But more recently, there has been some findings from ours and other groups that rank ligand also has an impact on muscle. That if the bone produces rank ligand, this rank ligand goes to the muscle and decreases the myonuclear number and content myofibrillar proteins and affect muscle metabolism. This is new. This is something that we are exploring very intensively because, and we'll talk about that in the treatment possibilities, because we have treatments at this moment, inhibitors of rank ligand, strong inhibitors of rank ligand. So that could provide a good therapeutic approach. Because measuring rank ligand is a little bit complicated because there are not very accurate kits in the market. So we use CTX, C-telopeptide, is a marker of bone resorption. So when our bones are resorbed, all this garbage that is produced by the osteoclast go to the circulation. Part of that is the C-telopeptide. So we can measure it as a surrogate of rank ligand activation and osteoclastic activity. What is interesting here, in this study, we did it with Ben Kirk and in Melbourne recently, is that we looked at the CTX, C-telopeptide levels in our patients at the Falls and Fractures Clinic in Melbourne, and we found that these high levels of CTX correlate very well or negatively correlate with performance or with indicators of muscle performance that we frequently use in our clinical practice, like sit to stand, time up and go. So here we have a clear connection between these two components. So to close my biological part of my presentation, this is a growing field, a growing, very interesting interaction between muscle, bone, geroscience, looking at it from the different mechanisms. So at this moment, we are running a different, separate and sometimes combined studies looking at all these different mechanisms within the context of osteosarcopenia. And for those of you who like hormones, definitely hormones play a role in this pathophysiology of osteosarcopenia. There is none of these hormone alterations or the hormones, alterations in these hormones that don't affect muscle and bone. All of them affect together muscle and bone. So again, coming back to if that condition exists, then there must be some kind of genetic predisposition. We have been working for a while with the group at the Rotterdam study in Netherlands with Fernando Rivadeneira, and we are trying to identify all these genetic changes that are associated with muscle and bone loss or specific markers of muscle. We have been able to identify some of them. I will not go into all the details. I already cited Brem Richards and Dr. Goldsman's results in a very interesting new molecule. So I think that genetics is confirming that we are talking about a condition that has changes in both muscle and bone. For the clinicians, and especially for the people who see older persons in this audience, we are always asked about, is there a phenotype for osteosarcopenia? We tried to identify the phenotype a while ago in Sydney with our clinic, Falls and Fractures Clinic, and characterizing about 480 patients at the clinic. And we found that the person who has osteosarcopenia, based on the criteria that we already mentioned, have this is older age, usually female, and of course all the parameters were much worse than the non-osteosarcopenic patients. We have been progressing a little bit more, understanding the concept of osteosarcopenia and the risk that this patient may have for falls and fractures. What we found very interesting is that 50% of people who come with fractures to the hospital, 50% of them with minimal trauma fractures, they are osteoporotic. But there is 50% of them who are osteopenic. They are not osteoporotic. So how come these osteopenic patients fracture? In our criteria, in our hypothesis, is that they fracture because they are osteosarcopenic. So they have osteopenia and sarcopenia. And aiming to demonstrate that, we have done a few studies. We know, for instance, that the severity of sarcopenia, those who have severe sarcopenia are at much higher risk of fractures. This is a study from our clinic in Melbourne. This one is from our clinic in Sydney, where we again, this is in 480 patients with a very, very relatively old patients, older than 75. We found that the risk of fractures comes from two things. One, if the person has osteoporosis and sarcopenia, definitely some much higher risk of fractures. But very interestingly, those who have severe sarcopenia and osteoporosis, particularly osteopenia, were at similar high risk of suffering fractures independently of the definition of sarcopenia that we used. These findings have been confirmed by several groups. This is a major meta-analysis also showing that patients with osteosarcopenia are at high risk of falls and fractures. And we also tried with one of my students to see if there is a specific pattern of fractures in osteosarcopenic patients. And we found that usually the non-vertebral are more prevalent in osteosarcopenic individuals. So the question in clinic is, what happens first? Is sarcopenia that happens first? Is osteoporosis? Is osteopenia? So we have two models that are assessing at this moment. We have been collecting data from about 10 cohorts in the body, in the worldwide collection and harmonization of data. So at this moment, we have data of about 800,000 people, older persons with the major, including the Canadian longitudinal study on aging. We are in the process of analyzing that data set. As you can guess, it's a very complicated process, but we're trying to answer this question: what happens first? So there is this linear model that we can consider. What happens first is, according to what we have identified, is maybe sarcopenia happens first, the person becomes weak, and the bone is affected, because bone metabolism is a little bit different. So bone osteopenia follows, then osteoporosis, all in the context of osteosarcopenia, and then frailty, disability. Then I propose this model later on, which is a dynamic model where the robust individual, person with normal bone and muscle mass, develops osteosarcopenia due to the presence of all these different risk factors that I mentioned. Then the person starts suffering falls and fractures, all the associated adverse events in osteosarcopenia, social isolation, fear of falling, physical dependence, and then it becomes a vicious cycle. And and then the patient definitely will jump into frailty, which is a further stage of inability to respond to stressors, and then disability, and the person is admitted into a nursing home. So which pattern is the one that happens? Or is it the linear, or is this cycle? This is something we are trying to answer, as I said, with consolidating a lot of data sets. We have preliminary data. This is preliminary data with Taiwan, with the Island study, a major study in geriatrics run with Professor Liang Kun Chen in Taiwan, a very strong collaborator of our program. So basically, we're trying to answer is it a dynamic model where people can be non-frail but have osteosarcopenia, then become pretty frail or come back? What happens in this kind of individuals? What we have found is that we try to identify what is the contribution using different models, multiple models, but this is just this is from Michigan Fatima, my Ph.D. student, who is also a geriatrician. And we found that the risk of having or developing frailty is higher in those patients with osteosarcopenia as compared to osteopenia, osteoporosis, or sarcopenia alone. And that's where we are at this moment. Hopefully we'll have an answer on these dynamic models once we complete the harmonization of all our data sets. So we want also, a part of the phenotype, we want to identify sarcopenia and identify it in clinical practice. So our group is also trying to develop new biomarkers that will be useful to diagnose and identify sarcopenia and osteoporosis at the same time. We are enemies of one concept, which is fragmentation. We don't like when we fragment into bone separately and muscle separately. Here we're trying to find biomarkers for both. So one of them that is very exciting for us is the circulating osteoprogenitors. These green cells here, we have been working on this for a long time. My PhD, Jack Feehan, is the author of this paper and multiple papers in this field. And basically what we found is that these are stem cells that are in our circulation. These stem cells are a very small proportion of our PBMCs, about 0.4 to 0.8% of our PBMCs. These cells are circulating, and they seem to have an impact in the way the musculoskeletal system develops and functions. Jack was able to, with our team, with Jack leading this project, were able to demonstrate that having good numbers, normal numbers of COP cells are associated with a normal muscle function. So muscle function is normal, and several studies by our groups and others, particularly our groups in the lower range and other groups in collaboration with us in the higher upper limits, we did three things here. We know the normal reference range of the COP cells. Why we like this as a biomarker? Because it remains steady throughout our life. So it's not affected by our normal aging. It's affected by pathology. And in the case of osteosarcopenia, the numbers of COP cells go down significantly, and they are much lower when the older persons have frailty. What is interesting is the opposite, which we have been working also in collaboration with some groups at the Mayo Clinic, is that if we have too much COP cells, we have heterotopic ossification, we have aortic ossification, and now we are working with another group in Columbia University where we identified that this could be also associated with lumbar spinal stenosis. So we can have too much, we cannot have too low, but in the context of osteosarcopenia, this is a good biomarker, a steady one with aging, but goes down in osteosarcopenia. But because, this has a preliminary studies, preclinical validation, we still can use our own tools at this moment. So we focus on to identify osteosarcopenia in DEXA scans. I mean, there are DEXA scans everywhere in the world. They're relatively cheap. So we say, okay, what is the place in the body that has more muscle and more bone together? And we found that it was the mid-thigh. So why not to measure mid-thigh instead of measuring the other typical sites? And because it also has fat, and let's see what happens. And we just published this. It appears as submitted data, but it's already published in the Journal of Bone Mineral Research by Sarah Bogrin, our biostatistician, which showed that in addition to being faster and easier to quantify, we were able to identify osteoporosis and low limb mass, and they are equivalent to conventional regions of interest. So we were able to identify, and also was associated with adverse outcomes, including falls, which is important here. So we don't need to go and do a whole body scan of DEXA. Maybe we can just have a very narrow area of analysis, and that way we can quantify lean mass, bone mass, and fat mass. Of course, it has the limitation that DEXA doesn't evaluate muscle mass, it evaluates lean mass, but it still is a good predictor of adverse outcomes. We are also working on something a little bit more sophisticated, which is analyzing CT scans and trying to quantify bone and fat. And you will see here, this is an example, we call it tissue compass. You see the blue here is bone. We can even extract the bone and quantify red marrow in the bone. And then we can even extract that red marrow and just quantify fat. So you will see now it's only in yellow. We can quantify those volumes. We can also quantify that in the muscle. You can see in the bottom of the slide. This is the muscle that we can extract from the images. This is an abdominal. I think this is L3, and then we can quantify at the same time the muscle infiltration. So we can approach and quantify this in osteosarcopenia, at the same time muscle and bone. This is a project by my Ph.D. student Madi Imani. At this moment, he's developing, we developed an artificial intelligence model that can analyze 200 CT scans per day, and we can calculate that very quickly and analyze the volumes regarding osteosarcopenia. So the last part of my talk, I mean, that was the optimistic part. Now we're going into a little bit more pessimistic part, which is therapeutic approaches. Unfortunately, we don't have a lot of therapeutic approaches that have dual impact. If we want to treat osteosarcopenia, we need something that works for both, for muscle and bone. So we know, and there are some studies now starting to show up, most of the studies have done separate bone or muscle, or have not considered muscle or bone from the perspective of osteosarcopenia. But some studies, one by Ben Kirk in Liverpool, and some of the studies have started to look a small sample size to look at the impact of nutrition and exercise. We in the recently published non-pharmacology systematic review on all the non-pharmacological interventions for osteosarcopenia, we didn't find any good randomized control trials. So this is an invitation for all the trialists in this audience, so people interested in muscle and bone clinical trials, to work together. We are happy to collaborate and do the clinical trials looking at osteosarcopenia. But nevertheless, we know that there are interventions that work for bone and muscle independently. Again, not very strong clinical trials in both, but we can still use, the usual story of vitamin D, protein supplementation, HMB, which is beta-hydroxybutyrate, and calcium supplements to maintain our bone and muscle health. But again, this is based on separate trials looking at the separate tissues. Laura Giangregorio at Waterloo University here in Canada is very interested in developing exercise programs with dual effect on muscle and bone. And this is important because sometimes coming back to fragmentation, our family physicians refer our patients to the bone and bone health, and they end up doing exercises for bone, and then the geriatricians we send to the falls clinics, and then we do exercise for falls. Why not to come together and do these kind of combined models for osteosarcopenia? Finally, what are we trying to do? One of the interesting recent findings by Serge Ferrari in Switzerland. I hope you remember the RANK ligand inhibitor, denosumab, is a very well-known drug for osteoporosis, very effective. They did a very nice study in animals where they demonstrated a high expression of RANK ligand affects muscle function and muscle differentiation. But at the same time, they did it in humans, and they compare bisphosphonate with denosumab. Interestingly, they expected to have a good improvement in BMD. They did. They improved appendicular lean mass, and they also improved muscle function. We did another small study looking at denosumab, and we found and zoledronic acid. We found that both inhibit the RANK ligand, and denosumab is definitely a stronger inhibitor of the RANK ligand, and also show a better effect on multiple measurements of muscle function. There is this recent study where definitely the treatment with denosumab prevents falls, and that's interesting because that could be associated with this effect. So RANK ligand inhibition probably is a good way to go. What about inhibiting the capacity of this fat to produce the toxic fatty acids? And this is our working hypothesis. We treated these mice with osteosarcopenic mice, ophorectomice, with an inhibitor of fatty acids, and we found that treatment with this inhibitor of fatty acids, cerulenin in this case, recovered the bone phenotype. And surprisingly, when we were looking at the results, we noticed this. I don't know, you can see this here in the panel A, where you see the muscle mass increased, and with this treatment. So we explored it a little bit more, and now we know that muscle mass doesn't only improve with this treatment, but also muscle function. I hope also that you remember the good ones, the good element of the story of the picolinic or of the kynurenine pathway. We have been treating mice with picolinic acid, and we found that they also recover the bone phenotype, not only the ophorectomice, but the sham operated. And at the same time, and this is also data from Ahmed Al-Saedi, where we treated myoblast with picolinic acid, showing an effect of picolinic acid, anabolic effect on muscle. So this is another perspective, another approach that we are making for this. And of course, this is something that we are working on. We already developed a method to collect, isolate, and expand COP cells. And now our next step is to collect COP cells from young donors and infuse these COP cells from young donors into frail older persons with osteosarcopenia. Similar studies have been done with bone marrow stromal cells. Here we have COP cells which are easy to collect from the circulation. And until we reach this point where we identify a treatment for osteoporosis and sarcopenia at the same time for osteosarcopenia, we have to develop these pathways and recommendations for our clinicians, where we recommend to the bone people to identify people with osteoporosis, patients with osteoporosis, to think about sarcopenia and vice versa. So in summary, we know that we are talking here about three sides of the same coin in the context of osteosarcopenia. If the patient has the risk factors, they develop the disease at the same time that affects muscle and bone. And this is potentiated by physical inactivity and poor nutrition. And these are the future direction. There's a lot of things that we want to do. This is a lot of things that we want to do here at McGill. And this is probably our job for the next 5 to 10 years, is to find all these different answers, identify the main pathways, trying to identify the good biomarker, and most importantly, try to integrate the model into falls and fractures prevention targeting osteosarcopenia. With this, I would like to thank all our collaborators around the world. Of course, this has been funded by Australian agencies, but hopefully we will start, developing our research program here. And I invite everyone in the department who is interested in these topics to contact me, and we're more than happy to collaborate. With this, I thank you very much for your attention.
Excellent. Thank you very much, Gustavo, Dr. Duque, for the fantastic, fascinating overview of osteosarcopenia biology, diagnosis, management. It was great. Maybe just to start off, my 85-year-old father-in-law swears on doing his free weights, his sit-ups, and his long walks every day. I was a bit discouraged to see that the exercise doesn't seem to make a difference. Is that exercise not making a difference in a prevention setting or in an established osteosarcopenia setting?
Well, the walking as an exercise is not effective on bone or muscle in terms of improving muscle mass or in terms of preventing falls or fractures. So in order to develop a real protocol to prevent falls and fractures and improve muscle and bone mass, it should have a combined set of components. It should have a resistance exercise with progressive resistance, and the second balance exercise, because sarcopenia and osteosarcopenia affects balance as well. So it has to be combined, and that way, with a regularity of at least twice a week, with a duration of at least 30 minutes per session, is something that will definitely improve muscle and bone mass and has demonstrated to reduce the risk of fractures. Okay, great. All right, we've got some great questions in the chat. Dr. Doss asks whether there's a crosstalk between mesenchymal-derived cells such as cardiac and arterial venous myocytes and adipocytes and bone. Here, yes, there are the two communications pathways here. One is the fat that infiltrates the heart, for instance, or the fat that infiltrates the pancreas, because this fat infiltration is not unique of osteosarcopenia. This fat infiltration is also observed in other age-related diseases. So there is definitely a communication between that fat that infiltrates and the cardiomyocytes. That's well known. There is a very toxic, very bad communication between the fat that infiltrates the pancreas and the beta cells that actually has been proposed as one of the combined mechanisms of diabetes. So there is definitely, whether there is communication between those cells and bone, I'm not sure. And I don't think anybody has looked specifically on the fat of this specific tissues. One of the challenges we have, and I'm pretty sure everyone that works with crosstalk and interorgan communication, is how to track the messengers, how to track the message in a way that you can demonstrate that one tissue is communicating with the other. Now we are working, I didn't mention that today, but because I mentioned a lot about that yesterday, we are working a lot on extracellular vesicles and exosomes as probably the carriers of those messages. And that's much easier to track. So, coming back to the question, I don't think I have seen any evidence of this particular type of fat in those tissues communicating with the bone, but there must be some kind of communication. Okay. And Dr. Sayadaco is asking about diabetes and whether insulin affects fat infiltration in skeletal muscle and bone. And is there an acceleration of osteosarcopenia in diabetics? Yes, and this is a very interesting topic now. There are a few groups working on diabetes. Diabetes is clearly associated. Well, there have been a recent 2 or 3 papers showing that diabetes definitely increases the risk for osteosarcopenia. So there were isolated studies in the past. There is a clear association between diabetes and osteoporosis. Clear. There's association between diabetes and sarcopenia is also very clear. But just recently, we have seen that the severity of osteosarcopenia is higher when we have a patient with diabetes. So definitely, and there are quite a few groups working on the pathways that are affected in that sense, because there is clear increase in fat infiltration in diabetic patients in both tissues, in muscle and bone.
Okay. And Dr. Moret has a comment and question. Jose, do you want to open your mic?
Yes, certainly. Great talk, Gustavo. You didn't discuss much about vitamin D, and I was wondering, from your interpretation of so many results on vitamin D, what is its role in maintaining bone and also preventing fractures?
Well, in the context of osteosarcopenia, vitamin D has been associated also. Vitamin D deficiency is a risk factor for osteosarcopenia. At this moment, we are looking at vitamin D not just as a risk factor for bone or for osteoporosis, but as a global risk factor for osteosarcopenia. Because vitamin D is an anabolic factor. Vitamin D induces differentiation of muscle, induces differentiation of bone. And interestingly, and this is part of the studies we did at McGill a while ago at the Lady Davis, we demonstrated with Dr. Richard Kremer actually here that vitamin D treatment of mice, all mice, inhibits marrow fat infiltration. So there is not only the component, the anabolic component of vitamin D, but also the anti-fat that could be observed in both, in muscle and bone. And comes back to my to the report that I show. I'm trying to find the role of vitamin D in both muscle and bone. Not many studies have looked at both tissues in the concept of vitamin D supplementation, but the separate evidence is very strong.
Yeah, if I may, is that about the walking, because it is something that is accessible to any older person as opposed to run or go to the gym. It is true that you need resistant exercise to build new muscle and maybe even bone, but walking has a strong impact on preventing loss. So by being active, you can maintain more muscle and probably bone as well by just walking. But once you lose some, then it's not enough as an impact to gain. It's my interpretation, and we could do some studies on that as well.
Yeah, patients have to walk a lot if they want to maintain the muscle and bone health.
Yes, but any exercise is better than nothing.
Yeah, no, that's definitely.
All right,
and it's good for cardiovascular health, and nevertheless.
Yeah. I'll tell my father-in-law to keep trucking. Okay. So Dr. Pilat is asking whether there should be sex-specific approaches to prevention of osteosarcopenia.
Yes, I agree. And definitely what we have found in the phenotype is that the women at a high risk of osteosarcopenia, more prevalent in women, but at the same time, some approaches that we have done in terms of looking at testosterone have been a little bit disappointing, especially in the clinical trials. So clinical trials with, and we just finished all the meta-analysis of the testosterone administration in older persons with osteosarcopenia, and the results are that it has an impact in men, in muscle function, and a little bit on muscle mass, mostly in muscle mass, in some bone mineral density in the hip, but it doesn't prevent falls and fractures. So if we want to prevent the outcomes, maybe we need a stronger combined approach. But I agree with the question. There's definitely we should have this differentiated approach because some of the risk factors are different.
Great. So we're down to the last 30 seconds or so. So I'd like to invite perhaps Dr. Duque to answer in the chat after the session is over for those residual questions. And once again, I'd like to thank you for excellent grand rounds. And it sounds like you've been a busy man. You gave excellent grand rounds at JGH yesterday. And, and welcome to the department. We're thrilled to have you, Gustavo. And thanks for today's overview. It was fantastic.
Thank you very much.
Okay, take care.